Okay, ladies and gentlemen, welcome to this podcast of a European Society of Anesthesiology and Intensive Care. We remind that this Industry Corner episode is currently supported by Nihon Kohden. And I'm your host today. My name is Chiara Robba. I am a professor in anesthesia and intensive care at Policlinico San Martino in Genova in Italy. And today we will be discussing a very important topic. The title is Silent Seizures, the role of a EEG in the ICU. And here we have invited Professor Mathias Gelderblom. He is a clinician scientist and clinical attending at the Department of Neurology, University Medical Center of Hamburg, Germany. Welcome, Mathias.
Yeah, well, thank you very much.
Okay.
Very happy to be here, to have a chance to talk to you.
Thank you very much for being here with us. So I have a couple of questions for you regarding the application of EEG, silent seizures, the use in the ICU. So first of all, can you please give us sort of a background regarding the potential applications of EEG in the intensive care unit, please?
I mean, it's the EEG is unique for us when we look at the different diagnostic tools we have in the clinical setting. I mean, in general, as a neurologist, but also in other disciplines, we rely very much on imaging. However, I mean, imaging, it's kind of, in certain situations, it's difficult to apply to the patients immediately, and also it just gives us morphological information, and we don't get functional information. So we are not actually assessing cortical function. Yeah, I mean, and that's why the EEG is unique, because the EEG is basically a technique which gives us in a bedside with the possibility to have a bedside recording, like an immediate view into the cortical function, insight into the cortical function of the patient. And so, I mean, and that's what makes EEG so valuable for us in a clinical setting.
Yes, I totally agree with you. I mean, there are sometimes some diagnostic challenges, no, in our patients in the ICU. Like we have difficulties in the diagnosis of altered status of consciousness in some types of patients. So from a clinical perspective, how do you use it? So which are the information which EEG can give us?
I mean, basically, you already mentioned one very important aspect, or one very important application. I mean, if you have patients with an altered consciousness, I mean, you can have various reasons for that, clinical causes coming from metabolic encephalopathies up to stroke, but also seizures. And one big challenge are non-convulsive seizures and on non-convulsive status epilepticus, because that's something, I mean, sometimes these patients with seizures or status epilepticus might show very subtle neurological deficits or abnormalities like movements and so on, or myoclonus. However, I mean, regarding the importance and also the clinical implication of the status epilepticus in a non-convulsive status epilepticus for the outcome of the patient, it's very important to have a precise and also fast diagnosis. Yeah, because we know, I mean, first of all, we know a non-convulsive status epilepticus is much more often than we think. I mean, if you look into the literature, you see that up to 10, depending on the study, up to 20% of patients on a general ICU with this disturbance of the consciousness have or meet the criteria of recurrent seizures or a non-convulsive status epilepticus. And so, first of all, we know that a delayed treatment in these patients is worsening the prognosis. I mean, in general, if you have a patient with seizures or a status epilepticus, this worsens the prognosis massively. If you do not recognize this, and if you don't start the treatment early on, it's also the treatment gets much more difficult. The longer you delay the start of your anticonvulsive treatment. I mean, that's important. And also, I mean, the other thing is we can't rely on our clinical experience and on our clinical examination, because I mean, even if you're experienced neurologists, there are no clear signs of a non-convulsive status epilepticus. And that's why we completely rely on the EEG.
Yes, this is, I think, a very crucial point. You mentioned the non-convulsive status epilepticus. You know, if a patient has clonic seizures, it's easy to detect it from a clinical perspective. In non-convulsive status, it's much more difficult. Sometimes we wake up patients, they are in the status of coma, we do a CT, and the CT is negative. So my question is, when do you do the imaging and when do you do the EEG? I mean, from a practical perspective, let's imagine a patient who had a head trauma. We wean him from the sedation because the ICP is under control and the patient doesn't wake up.
I mean, the nice point is that these are two techniques which are going in parallel. You know, one technique for the imaging, you will always do an imaging because, I mean, it's something which is accessible for us. And so we want to make sure that there's no stroke, etc. And so, I mean, we will do imaging, but at the same time, we also have to keep in mind that the EEG is closing is answering another very important question. And once the CT scan and also your lab results, etc., do not explain the status of the patient, you want to proceed rapidly and do an EEG. Because, I mean, it's funny. I mean, if you go on an ICU, it's very easy to get a CT scan, and it's probably harder to get an EEG, right? And also our knowledge in interpreting EEGs is probably not as good as interpreting CTs. And that's why, I mean, these are basically both methodologies you want to combine in a patient.
Yeah, I think you have touched a very important point. Sometimes it's hard to have an EEG. You are a neurologist. For instance, I am an intensivist, and not all intensivists are able to assess properly an EEG. Sometimes in some units, it's also difficult to ask someone who comes in the ICU and does an EEG when we need it, because you mentioned an important point. So the importance of the time, the more we keep the patient in a non-convulsive status epilepticus, the worse will be the outcome. Which are, in your opinion, the challenge in the use of the traditional EEG in the ICU?
Yeah, I mean, it's like with echocardiography, right? I mean, nowadays, more or less, an experienced anesthesiologist is pretty good in echocardiography for like basic questions, right? And this is something which developed in the last, I would say, 10 to 15 years probably, right? Also with the development in sonography in general. And I think something similar could potentially also be applied to EEG, because reading EEGs and setting up an EEG is much easier than most people assume. You know, the first question is always, which EEG do you want to use? Okay, so because, I mean, we are now, I mean, in general, we use this 1020 system with 21 electrodes, surface electrodes. That's not something you have to apply in the context of an ICU. You can also look at montage with fewer electrodes. Sometimes it's even okay to do a mobile EEG. I mean, there are mobile EEGs on the market which are giving excellent EEGs with only 6 to 8 electrodes. And then you have a very good impression of both hemispheres, and you see most of the relevant of significant pathologies. You will find with these, like, let's say, more simple approaches. However, I mean, the most important thing is, and that's why you need a basic understanding of EEGs, the raw signal. So first of all, the signal, when you apply EEG with a smaller montage, it's more important to have a good raw signal than to have many electrodes. Yeah, because you always have the difficulty in an ICU environment. You have a lot of noise, a lot of disturbances from the patient, but also from the bed, from the ventilator, etc. So that's the first thing. So you want to have an impression of your EEG signal. So that's the first thing, because the pathologies you are interested in. They are not that difficult to detect if the EEG signal per se is okay, right? And that's I think that's the bigger challenge. So you have to understand, how does a normal EEG look like in general? What are the basic filter settings you need to apply? Where can you make changes? What are the parameters which you shouldn't change, because otherwise you kind of change the EEG signal? And then it's to detect the status, a non-convulsive status epilepticus, or to have or to also detect significant finding for the prognosis of a patient, like a burst suppression pattern. That's not so difficult, and that's actually something which you can learn easily, and which is also, also we have nowadays these trend softwares. They have spike detection. They have you can use these spectrograms also to detect non-convulsive seizures in an EEG. So there are a lot of tools which you can apply, which are helping to interpret EEG. But I think, again, the most important thing is, what is your approach? First of all, which EEG do you want to apply? Do you want to apply with the 21 electrodes an EEG? Do you want to do continuous EEG? Or do you want to do on a spot, 20-minute EEG, which is also okay? There are studies showing that you don't necessarily need continuous EEG, because if a 20-minute EEG does not show any significant pathologies in terms of epileptiform transients, changes, then the risk is massively reduced as this patient develops seizures, for example, or non-convulsive status.
Thank you. I think that you are right. Probably it's less difficult than we think. We are just a bit scared about putting our brain in learning something that was considered just for specialists. But I also think that the technology is helping us a lot. So I was wondering, can you go a bit deeper in new user-friendly equipment, or, for instance, automation, or we are in the area of artificial intelligence. How do you think that all these tools, how are evolving, and how do you think can help?
First of all, I think when you look at, first you should look at hardware, right? So what EEG montage do you want to use? And there are excellent new products on the market which are giving you, with a small montage of 6 to 8 electrodes, a very excellent mobile Bluetooth EEGs, for example. So you apply these, let's say, headsets on a patient, and then you have a computer remote in the room, and a Bluetooth EEG, and this gives you excellent EEG recordings with a very good quality. So first of all, you have a very good signal to noise ratio, etc. So that's actually the first thing. The next point is what you mentioned. When you do continuous EEG, you need tools to monitor your EEG, because in general it's your consultant comes 1 or 2 times a day on the ward, looks at the EEG, but he can't screen through 12-hour EEG monitor. That's impossible. That would take him an hour. So he will not be able to do that. So that's why you need trend software, because there's this new trend software, and there are also a couple of options on the market now. They give you very good indications of pathologies which are evolving over time in a long-term recording. And they give you clear indications when you look at spike detection or seizure detection, for example. These tools are pretty good to then screen certain episodes in your EEG and to see, okay, is there something interesting? Do I find it a specific pathology? Do I find seizures, for example? And that's why this trend software is very important, or very, very helpful actually, and facilitates EEG. However, you always have to keep in mind the raw signal has to be good, okay? That's just, I can just emphasize that, because just looking at these trends is dangerous. So you should always have the raw EEG signal. Just look, because I mean, if some electrodes are dislocating, whatever, are getting lost, then you can't work with that anymore. So that's why. But I mean, that's the same in every other technique also. And with echocardiography, I mean, the image has to be reasonable in the first place. And that's why that's also the same is true for EEG. The signal has to be reasonable, and if you have a good signal, you can work with all this new trend software. And I mean, when you talk about AI and machine learning, I think we will. I mean, I think it's too early to comment on that. I think right now there are lots of people working on new algorithms to improve the analysis of EEG, but there's nothing which we can apply nowadays and which really helps us. I think what helps us is these trend softwares which are on the market, which are very good, which can be combined with continuous EEG, because the software is actually there to facilitate, to make the analysis of your EEG easier.
Yeah.
I think, I mean, it will be interesting. I think in 5 years, this will be completely different.
Well, 5 years is not a long time, so we will see. And again, as you were mentioning, expanding technologies is improving the noise resistance. It ensures more data accuracy, correct?
Yeah. I mean, that's a point, and that's why, I mean, if you want to implement EEG, I think the most important point is you have to make a decision. What machine do you want to use on your ICU, right? And that's something you should invest some time and because as I said, there are excellent systems on the market, and this makes your life much easier.
Yeah, true. Now, as a last part of this video podcast, let's talk a bit about the prospects in the clinical application. In your ICU, in your dream ICU, how will EEG be applied, both for early diagnosis, but also I was thinking about expanding application like EEG as monitoring tool, like monitoring of long-term neurological recovery, etc. How do you see this?
Well, I mean, once you're able to apply EEG on an ICU, it will be much more, I mean, it will go far beyond seizure detection or also control of status epilepticus, for example. I mean, just think about subarachnoid hemorrhage, like cortical dysfunctions and vasospasm. I mean, that's a huge clinical challenge we have today, and all the techniques we have are only giving an incomplete picture of what's going on in these patients. And I think that's, for example, one patient subpopulation or population of patients in which we need much more precise monitoring of cortical function, or let's say dysfunction. And I think these are typical applications in which EEG could be extremely helpful to guide therapy. I mean, because what we are doing is obviously not always sufficient to guide the therapy in these patients, or to decide what's the next step, or where do we have to escalate our therapy? Who's going to the angiography for local nimodipine application, etc. Right? And I think this is just one example of patients in which I think that EEG, with the direct view on cortical function, insight into cortical function, would be extremely helpful, because we are not relying on flow and Doppler or on morphological parameters, because then we would really have an insight into does the vasospasm affect cortical function, and that's actually something we are interested in.
Yes, this is so true. Mathias, I really would like to thank you, because you have been very clear and your message have been really straightforward. I think that we are at the end of this episode. I really would like to thank everybody for listening this episode, but mostly Mathias for being with us. And I just would like to remind you that the ESAIC releases monthly podcasts on the ESAIC website and on various streaming platforms. So we hope you will join us for the next one. Thank you very much to all of you and for listening.
Thank you, Chiara. Thank you very much.